Heidi Harris is our global leader also for product. Let's wait for Heidi.
Hi, everybody. How are you?
Okay. Hello, Heidi. So,
hello.
If let's start. Okay, we have your time here. Thank you very much.
All right, great. All right. Buenas noches. I wanted to take some time today to talk about our commercial offerings when it comes to prostate imaging. Kind of building off of, what Rob had talked about and applying it into a clinical setting. And then Dr. Boyces will be probably taking this even further on prostate imaging as well. So just some simple prostate cancer facts. 1 in 9 men over the age of 50 are diagnosed with prostate imaging. Obviously, the earlier it was detected, the better prognosis long-term. And this is, the average age is about 66 when cancer is detected. And of course, that can always range anywhere between 50 and 70 years old. This is the fastest growing clinical area. We've looked at data, whether it's, in the US or globally, that this is where we've seen the highest percentage of growth opportunity. And that's simply because you have a better care pathway, which offers a non-invasive solution, as opposed to high PSA, go for a biopsy, to go for, an MR maybe. And, going that route, you have a tendency, it's kind of a blind biopsy, but you have a tendency to miss about 20% of those cancers. So, with the scientific community, they've been proving the fact that high PSA, and inserting an MR in between, and be able to stage where that cancer is or identify according to the standards, and then sending for a biopsy to be able to, have a more targeted approach. With prostate MR, and what we've really been able to do with AirRecon DL and our Air solutions is be able to provide a simply better experience. Flexible coils, blanket-like coils. We know our customers or the patients that we're targeting aren't the most, don't necessarily want to be there. So we want to offer probably the best experience that we can. We have a number of coils available, whether that's the large anterior array or the more targeted MP array or the multi-purpose large or medium to be able to cover. With our prostate commercial release, we have a full wing-to-wing solution. So as I mentioned, that the flexibility and the comfort of the air coils, utilizing AirRecon DL in the exam itself, the sequences itself, and then being able to quantify that with deep learning ProView, which allows us to identify and stage as well as report what that PIRAD score is. So we're very excited about being able to, soon into the future, be able to provide a full wing-to-wing deep learning experience. So improving that speed and contrast. As Rob had shown before, what AirRecon DL brings to whether it's prostate imaging or in general, taking those noisy images and being able to capture the signal, but remove the noise and improve the resolution. So how does that play out into prostate imaging? With the resolution, we're looking to, it's all about the PIRADs and the scoring when it delivers. So very strict parameters that are used, really built off the 3T. With AirRecon DL, we're able to exceed what those values are and the resolution standards, and still maintain the image quality, and if not, if anything else, improve that. But also to be able to achieve the PIRADs in a 1.5T, which opens up a lot of different opportunities, whether it's expanded service line, or if you're able to move a patient off the 3T into the 1.5 for whatever reason. But not only that, we're able to do that in a 10 or 15-minute time period. So just looking at the PIRADs protocol, 3T2s, a diffusion, and a dynamic scan. And then, whether you achieve that in the 10 minutes or if it opens up the possibility to add some additional sequences, maybe a large field of view to check for any sort of lymph nodes. And as Rob was talking about too, the SNR that you're gaining and higher p-value opportunity to really, in general, be able to reduce the scan time on the critical diffusion sequences, but also, reducing the slice thicknesses to 3 millimeters. If the T2s, it'll line exactly to the T2s as an overlay. So something which was always challenging before. So let's look at signal to noise. This is off of one of our 3T systems, being able to capture each one of the T2 images, in less than 2 minutes. I know that this site in particular may not adhere to the PIRAD standards in particular, but was necessarily going for more of the speed. And that's what we're seeing here is no trade-off between the image quality or speed and signal of that exam. Focus diffusion reduces the phase field of view within the direction and also helps drive image quality and resolution in itself. In talking about speed, as we mentioned, diffusions, as you know, is the most critical sequence. And looking at a conventional protocol of 1.8 by 1.8 at 3 minutes or 3 millimeters, looking at about a 4-minute exam. With Air Recon DL, we're able to not only improve the voxel size, but also do it in a faster scan period. So increasing the sharpness and resolution by 30%, but also making it faster. You all know that MR is always about trade-offs, and with Air Recon DL, we don't have to make those choices. So as I mentioned earlier, exceeding this, the specifications on the PIRAD specifications with 3T, 0.4 by 0.7 by 3 is the PIRAD standards. So here we're able to drive that down even further with about, in under 1 minute and 30 seconds. Again, being able to, improve that voxel size and the slice thickness overall. We know that this is probably the most critical sequence when it comes to our T2s. And then again, with the coronals being able to capitalize on that as well. Diffusions, so we utilized an 800 and then synthetically created the 2500. That can either be done, at the scanner automatically or even done afterwards. Let's say the patient had left and you don't have to call them back for an additional scan. You can simply scroll through the different B values within there. For our dynamic scans, we'll go over a few of the options. Disco provides us a faster temporal resolution and spatial resolution. So we're not sacrificing. In this example, we're able to get down to 8 seconds per phase. Should you not want a fat sat or a water separation, that can get down even lower to maybe about 3 seconds. We utilize hypersense on there to improve that speed and resolution as well. So we talked about, exceeding the high-res resolution, but what about achieving them on a 1.5? Well, if you tried that today, we're looking at about a 45 to 60-minute exam on men that probably don't want to be there in the first place. So, being able to provide a faster solution really helps our patient population. So again, looking at the PIRAD standards, all being able to do that under 3 minutes. On our diffusion sequences, we can synthetically create those higher B values as well as the ADC, and then offer a dynamic sequence with that. We recently actually in this current issue of Signal Pulse, we did an article on prostate imaging for the 1.5 T system. So you talking with 3 of our KOLs globally, and they've provided their experience and helped give examples and how they utilize it in their place. So in one particular area is hip implants. We know that doing it on a 3T inherently has challenges when it comes to metal within the body and having that distortion. So it's on a 1.5, it's greatly reduced. And if we think about, if the average age for prostate cancer is 66, average age for a hip implant is 65. And of course, all these things can happen between the age 50 and 70. How are you actually imaging those patients? And, maybe even later as they get an implant, how do you follow up with them over time? Are you constantly, do you go year after year and do a biopsy when you may miss 20% of those biopsies? Or, what if you had a solution in a non-invasive way with MR, for example, to be able to improve that? Here's a great example on the 1.5 bilateral hip implants. And we noticed that we're not necessarily getting that ballooning artifact, or where it's impeding into the prostate itself. Metal within the body, of course, these are on MR conditional implants. On a diffusion is especially challenging because you don't have that echo train to help refocus the pulse. So in this case, we're still able to get a really great diffusion sequence and be able to identify the lesion within them. Coincidentally, was on site at a customer site, and the patient, was scheduled for the MRI of the prostate. They scheduled them on the 3T, and wouldn't you know it, he had a hip implant. So luckily, this site had a 1.5 that was right across the way. So we did do some scans on the 3T. We noticed that, the artifact that starts to kind of impede into, the hip area or just outside the joint, and how it's more well preserved on the 1.5. Overall image quality, you're getting better signal to noise in this area as well. But as I mentioned, diffusion, the hardest sequence to be able to refocus that artifact. And here it is on the 3T, this big ballooning artifact. Prostate should be here, but we're also seeing that other hip implant. So how do you make your diagnosis on there? Well, when we moved them to the 1.5T, we were not only able to get a better diffusion without that ballooning type of artifact, but we're able to establish that this patient actually had a PI-RADS score 5 in there. So not only does he have a care pathway where if he goes for a biopsy, which I'm assuming he would, they can automatically see directly where they're going for. But not only that, is now they're able to continue to follow their care afterward to see if there's any reoccurrence of tumor and so on. So again, really extending and opening that availability for patients that we really weren't able to scan before. And since AIR Recon DL is available across our entire commercial offerings, it really gives us a lot of opportunity. Patient comfort, let's consider that. Endorectal coil was always the choice, especially early on, to be able to gather that signal. But from the study that was actually done out of MD Anderson, they found that the air coil plus AIR Recon DL really provided better, or the same, if not better, of experience. So not only was it more comfortable, but actually we're getting better image quality. So here with the endorectal coil, you'll always get some, since the coil is here, you'll always get some sort of signal intensity that starts to even go outside the area. Here, we're not losing any of the signal to noise. We're actually maintaining it, and we're able to reduce that artifact. So feel free to use the QR code to capture the paper, but really at the outcome and the conclusion is that prostate imaging without the use of endorectal coil and utilizing AIR Recon DL really makes a difference for them. Dr. Odo, very big in the prostate world and helps, works within the PI-RADS to help identify them. Strong proponent of the endorectal coil. I worked with him. We tried to get him off of that, but did not budge. But he really felt, in their practice that AIR Recon DL and the air coil has given him the confidence to be able to move away from the endorectal coil. So again, University Hospital being able to provide a better opportunity. And in this case, for example, the patient refused the endorectal coil, and we can see why. He has a pretty substantial enlarged prostate. So looking at a large field of view imaging, we have a number of T2s that are available, whether it's single shot, 3D cube, or a lava sequence to be able to get that broader coverage, and we can use that one post-CAD. But also looking at our diffusion options. Rob walked through why these, what the benefit is of Air Recon DL is for diffusion, whether it's the EPI, which is for a larger field of view, focus to reduce the phase field of view and help to reduce the distortion, Muse, which is our multi-shot diffusion, and then of course the synthetic diffusion or magic DWI that we have to offer. All, with the exception of Muse, are compatible with Air Recon DL. So continuing to drive the improved signal to noise, higher B values without that added extra time. We have a great example of, just the choices of diffusion. So whether that's the EPI sequence, just a standard diffusion, what focus actually brings in, you can see that, a lesion that's here that it's identified better, or the multi-shot Muse image, which also helps drive that even further. And then another example of focused diffusion with a pretty substantiated lesion. As I mentioned, synthetic DWI performed directly on the scanner, as automatically once the scan is done. But let's alleviate the problem for the patient to come back. If there is a lesion that is bright on a 1400, but you want to see what it looks like on a 2000 or a 2500, just simply move the slider bar, and it'll be able to reduce the patient to actually have to come back. Our dynamic sequence, so kind of filling out that whole PIRADS, the protocol, various flavors, if you will, whether you're looking for a high tempo resolution, or if you're looking for, a fat sat or a non-fat sat sequence. And that just really kind of helps identify what that will bring to you in your clinical practice. Kind of putting the whole piece together, whether you're doing the disco for that, the tempo resolution to be able to characterize the permeability with GenIQ, or just being able to provide the fusion of either GenIQ or the diffusion over that. All are easily at your fingertips. As I mentioned before, I know that many might be familiar with ProView DL. Again, it uses the deep learning based lesion segmentation to help not only calculate the PSA density, but the measurements for an easy scoring and reporting. You can be able to calculate the prostate volume, the lesion, and then be able to score that directly. You can paste the lesion, or it automatically adds the lesion onto the sector maps, which is always, if you want to move that, then that's fine. And then the output of a PDF report, which you can send over to PACS or send over to the referring physician, and you can, capture any of these images directly on the report as well. So don't take my word for it. We have a number of collaterals that our colleagues and radiologists from all over the world have talked about their experience. We captured many of the body articles, as well as prostate, in our BodyWorks Signa Pulse article, booklet, I should say. And then in this recent issue of Signa Pulse, which is out now, and again, you can use the QR codes to capture both of these. We walked through, how do I choose what dynamic 3D to use throughout the body? And then, as I mentioned earlier, the PIRADS, being able to achieve the PIRADS on a 1.5, and, talking with, one of our imaging centers in Germany, one of our, larger hospital systems in Virginia, and at a academic hospital with Houston Methodist. And so with that, I'd like to close and thank you very much for the opportunity to talk further about this, and I'll turn it back over to you all.
Heidi, thank you very much again. Thank you for our presentation. Terrific. Actually, the images are great. I mean, and we have one question related to that.
Sure.
We know that prostate are more focused on 3T, right? Usually. Mm-hmm. So do you think with Eric on the L, do you think the demand will drive it also to 1.5T because of the image quality?
From feedback that we've gotten from our customers, they have been able to either expand the services. So, maybe on an imaging center where they do only have a 1.5, and they've been able to achieve it, right? But, in a 50 to 60 minute time period, that takes a lot of time out of the workflow of the daily schedule. Here we're able to achieve the PIRADS in an acceptable amount of time for those patients. So even if it's, 2 patients an hour, that opens up, a lot more opportunity within there. But I certainly welcome, everybody else's feedback and experience with that as well. But, as I mentioned in that article, they really walk through, hey, I've always used 3T, but now this really opens up, especially for the hip implants, for the patients that can't go on a 3T.
Yeah, perfect. Okay. Well, Heidi, thank you very much again. Thank you for coming for the Signals Masters Latam, and hope next year will be in person, okay?
Sounds great. Thanks again for the opportunity.
Thank you.